Good morning, everybody. Hopefully you're feeling refreshed after the coffee, tea and Sonic's tea cakes. So welcome to the session entitled Informing Elimination Strategies and Harm Reduction Policies through Bio-behavioural Surveillance, surveys among people who inject drugs. Now, this session is going to run in a particular way. So we're going to start with me doing a brief introduction to the context. We're then going to go quickly through 3 presentations, and then there's going to be an introduction to a group discussion and chance to ask lots of questions, to raise issues, and hopefully have some discussion. As we've only got an hour, it's quite time, so apologies for the sort of quick-fire start to the session. So, a bit of an overview. Oops. So this session will explore the pivotal role that repeated bio-behavioural surveys among people who inject drugs can play in reducing harm. This session will look at 3 established systems or surveys from high-income countries. And I apologise for the focus being on high-income countries, but this is to reflect that these are different systems, but in countries with perhaps broadly similar kind of context. Oops. So it will explore how bio-behavioural surveys can be used to inform elimination strategies and harm reduction policy, help us answer a range of research questions related to harm and preventing harm amongst people who use drugs. And in addition, we'll highlight the impacts of these 3 bio-behavioural surveys to date. So bio-behavioural surveys, for those that don't know, are surveys in which a biological sample and behavioural information are collected together. You're usually collecting a biological sample, and at the same time you gather information using a questionnaire, whether that's self-completed or interview, and they're often a core component of what's called IBBS, or Integrated Bio-behavioural Surveillance or Systems or Studies. These type of surveys have been widely used since the late 1980s to help understand the extent of blood-borne viral infections and risks amongst people who use drugs. These were initially focused on HIV in response to the HIV epidemic, but more recently have been particularly focused on hepatitis C. But they can look at a wide range of health issues, harms, etc. They have been implemented in many countries across the globe. Sometimes it's just one-off or ad hoc surveys. Occasionally there may be a series of such surveys in a particular location. But sometimes they're implemented as a programme of surveys to be repeated over a number of years, perhaps to evaluate the impact of a particular intervention or programme of interventions. And a number of settings have used these as effectively public health monitoring systems, where they've been designed to run over many years to provide key information to help inform responses and to reduce harm. They can have a variety of geography, from cities to regions to nations. But one of the key challenges for conducting such surveys is the lack of a sampling frame for the key population that you're looking at. And this results in the use of a wide range of recruitment and sampling approaches. So this session is going to focus on those bio-behavioural surveys that are repeated, and particularly those that are repeated in the context of public health monitoring or surveillance. Surveys that have been undertaken in a consistent approach over many years. And these will vary from studies taken annually to every few years, and different levels of coverage and recruitment approaches. Such surveys have been undertaken in many countries across the globe. We're going to look at 3, but there are other similar surveys in Australia, the US, and the Ukraine, for example. So the 3 surveys that we've got people from in the session speaking are the TRACS survey in Canada, the Unlinked Anonymous Monitoring Survey in England, Wales and Northern Ireland, and NESI in Scotland. These surveys are all long established. They have similar sample sizes, but they do operate in different ways and have different frequencies of sampling. We shall also be drawing on data from the Australian survey, the ANSP, which again operates in a not dissimilar way and a similar broad context. Okay, so I'd like to move on to the first of the speakers.
Okay, thank you. Thank you, Viv, for that rapid overview. I'd now like to introduce Monica Dezay, who's a consultant epidemiologist at the UK Health Security Agency, to do the first of 3 talks. Over to you, Monica.
Thank you. I think this is back to your slides, Viv. How do I... Do I just... there we go. Sorry, I'll just go back. Thank you very much. So I'm going to talk a bit about how we can use bio-behavioural surveys to inform and evaluate elimination strategies. So I'll focus on the unlinked anonymised monitoring survey to start with, but I'll draw upon examples from the other surveys as well. Just before starting, I don't have any disclosures to any conflicts to disclose. Okay, so the Unlinked Anonymised Monitoring Survey. This is one of the longest running surveys amongst people who inject drugs in the world. It's been running for over 30 years. We recruit survey participants every year, about 2,000 to 3,000 participants who have ever injected a psychoactive drug. Participants are recruited from England, Wales and Northern Ireland through drug and alcohol services, and we aim to get a nationally reflective sample. We also recruit participants through different services such as needle and syringe provision, bloodborne virus testing, and outreach such as homeless outreach. So all of our participants provide us with a biological sample, a dried blood spot, and complete a short behavioural questionnaire, and these two are linked by a unique identifier, but the survey methodology is unlinked and anonymised. The dried blood spots are tested for evidence of HIV infection, so that's with antibodies to HIV, evidence of ever being exposed to hepatitis B with antibodies to Hep B core antigen, current and chronic Hep B infection, so we test for hepatitis B surface antigen, ever exposure to hepatitis C, we test all samples for antibodies to hepatitis C, and we test all of our samples for evidence of current infection with hepatitis C, so hepatitis C RNA, so not just those who are antibody positive. So this gives you an example of the kind of data that we produce through the Unlinked Anonymised Monitoring Survey. It's a repeated survey, so we're able to look at trends in changes in HIV, hepatitis B, and chronic Hep C prevalence through our biological sample. And through the behavioural survey, we can look at trends in awareness of infection, changes in self-reported testing uptake, treatment uptake, vaccination uptake, risk behaviours, and socio-demographic variables. Now, the data from the Unlinked Anonymised Monitoring Survey has been really important to provide data to improve services and advocate for funding for services for people who inject drugs. In England, Wales and Northern Ireland, it's one of our only data sources that captures the bloodborne virus status of those who are unaware of their diagnosis. And we've used these data to characterise the population to try and adapt services to try and help diagnosis and engagement. And these data feed into our prevalence estimates. The survey provides longitudinal data to help us characterise underlying levels of risk and how this might have changed over time, and how service utilisation has changed over time. And this has been really important to help us contextualise why certain outbreaks, for example, might have occurred. So a recent example is the outbreak of hepatitis C and HIV in Northern Ireland, where through the UAM survey we saw a change in drug pattern use, where we saw an increase in cocaine injection and increased needle and syringe sharing, and that informed interventions to try and stem the outbreak. Our data also feeds into national models to estimate overall hepatitis C prevalence, chronic prevalence, feeds into incidence models and estimates for the number of people who are injecting drugs, and has been really important in helping to monitor progress towards elimination targets. The UAM data has been really helpful in framing policy-relevant research, and one example that Joseph will talk about later is the EPITOPE study, which looks at the impact of treatment as prevention on hepatitis C prevalence. And the data from the UAM has also been really helpful in informing reviews such as the Dame Carol Black review, and has provided data particularly on the limited resource that's gone into harm reduction historically in England, and hopefully increased investment in the renewed drug strategy. So this graph here gives you an idea of the kind of data that we produce through the UAM that's been used to help monitor and inform elimination strategies. So in the graph on the left, you can see here we've got overall antibody hepatitis C people who inject drugs in the survey who are antibody positive, and of those that have hepatitis C viremia in the light blue shaded bit of the graph. And what you can see is that there's been a decline over time, particularly from 2017. So the data from the survey has shown a decline in hepatitis C chronic prevalence amongst our survey participants. But alongside this, we've also seen that there's been no change in hepatitis C antibodies amongst recent initiates, which suggests that there is ongoing primary infection. And this, together with treatment data, suggests that the impact we're seeing with chronic viremia is primarily driven by rollout of directly acting antivirals, but we have had historic underinvestment in harm reduction. So the data from the UAM also, as I said earlier, feeds into our modelled estimates of chronic hepatitis C prevalence, and we triangulate multiple data sources using a force of infection model to generate data at the population level and also overall for people who inject drugs. So the data that feeds into this prevalence modelling is from the Unlinked Anonymised Monitoring Survey, estimates of people, the number of people who inject drugs. We also use endpoint data from on severe liver disease and mortality data, estimates of disease progression probabilities, and treatment data. And this all feeds into a modelled estimate of chronic prevalence that you can see in the graph on the left that shows you how chronic hepatitis C prevalence, estimated prevalence, has declined over time, particularly from 2017. And if you look at the dark blue part of the graph, that's the estimated prevalence in people who are currently injecting, where we've seen a significant decline. And we also see a decline, but less so amongst those who've previously injected or who report no injecting history. And we've also used the data to feed into some of the pilot work that WHO did earlier this year. England was one of 7 countries that contributed to the pilot to try and understand the systems and processes that are in place in different countries to be able to monitor progress towards elimination for hepatitis B and C. And I've circled here where the data from the UAM has contributed to evidencing our progress towards elimination for some of the WHO targets. So we use a proxy marker decline in chronic prevalence to estimate, to provide evidence for the incidence target. The UAM also provides our only data source on NSP coverage and contributes to data on OAT coverage, and also provides data on the proportion of those living with chronic hepatitis C who are aware of their infection. Now, NESI has seen really major progress towards reducing hepatitis C prevalence, and here you can see data from the NESI survey in Scotland that has been really powerful in demonstrating the decline in hep C viremia between 2015-16 to 2019-20. So if you look at the whole of Scotland, prevalence is reduced by 50%, which is fantastic, and this is even more marked in Tayside, as John Dillon described earlier today, and also in the Greater Glasgow region. Data from the TRACK survey in Canada has been really important in monitoring and informing elimination strategies and advocating for wider rollout of directly acting antivirals. And this paper here from Joseph Cox's team shows you the modelled estimates that estimated the potential impact that widespread rollout of directly acting antivirals could have on chronic hepatitis C viremia. And then moving on to data from Australia, these are data that were presented earlier today by Natasha Martin, and these are data from Jenny Iverson's team. So the survey in Australia links individuals using pseudo-identifiers and has established a kind of incidence cohort whereby they've been able to follow participants over serial survey years who are hepatitis C antibody negative to see whether they seroconvert. And what they've seen comparing the pre-DAA period to 2016 to 21 when DAAs were rolled out is a really marked reduction in hepatitis C incidence by 58%. And again, the graph that Natasha showed earlier today shows that there's been a real sort of step up in people living with chronic hepatitis C who've had access to hepatitis C treatment from about 2016 onwards, and this has corresponded to a similar decline in hep C viremia from around 2016 onwards to just 16% in 2021. So to summarise, representative, repeated bio-behavioural surveys can be really helpful and really important in monitoring our progress towards elimination and evaluating the impact of strategies to achieve. But I also want to emphasise here maintaining elimination. They're really central to strong monitoring and surveillance systems and will be important for ongoing monitoring of maintenance. The longitudinal data that we get from these surveys helps determine trends over time. They can help identify need for and help us to advocate for policy changes and investment. And they've also been really helpful in helping contextualise and understanding how changes in risk might contribute to achievement or not of elimination. But there are challenges, as Viv alluded to earlier, that hopefully we can talk more about in the discussion, including representativeness and sampling frame, funding, and recruitment to surveys. Thanks very much.
Thank you very much, Monica. What we're going to do is leave the questions till after the presentations. So it's my pleasure to next introduce Dr. Andy Macaulay, who is a reader with us at Glasgow Caledonian University and consultant scientist at Public Health Scotland. Over to you, Andy.
Thanks, Sharon, and thanks, Monica, for such a great introduction there. The format of this session today was to try and reflect the kind of collaborative nature all these different surveys work with each other, so we're going to try and reflect each other's results in different areas as we go through, and I think that was a great start. So Monica's got the really sexy Hep C elimination stuff. I've got the other side of bio-behavioural surveillance, which focuses on kind of harm reduction policies. Are we working? Okay, try using the mouse. Nope. Will I clap? Oh, wait a minute. So that's the wrong presentation. That's the right one, but it's not moving. Okay, 1 minute. I'm getting a call. You can just marvel at this lovely opening slide, which I didn't spend much time on, unfortunately. Okay, here we go. Great. So backwards, forwards. Okay, yeah, so the background to NESI, we've not been running as long as the UAM, but the NESI surveys go back to around 1990s when they started in the Glasgow area, and they've now been mainstreamed across mainland Scotland since 2008, and we run every 2 years. Our methods are very similar to what happens in the UAM. The main difference is that we use recruited field workers to do our data collection, as opposed to UAM, who use people already working within services. And generally we recruit around 70% of our 2,500 recruits every 2 years are people who have injected drugs recently. The one thing to say about working in bio-behavioural surveys is they're really good fun. Every couple of years we recruit new field workers. Sometimes they're people who have already worked in the field, sometimes they're people who are completely new to the field. And one of the most rewarding things for us is seeing those people go through that journey from being trained with us, going out across the country to all the different pharmacies and drug treatment services, engaging with the populations, and quite often we see people then go on to careers in the field after that, outside of our surveys, and for us as researchers that's really great to see. And we do hear some really great stories of their tales in the field. There are some of our ex-field workers in the audience today and some of our stakeholders who facilitate access, so yeah, it's good work to be involved in, and this just gives you a graph of what happens. We get them trained up, we give them a backpack, out they go to the pharmacies, collect the data. It goes to the lab. We also process all the questionnaire data. We mash it about in the computer and we get these nice outputs at the end which contribute to different impacts. So today I'm going to concentrate on the harm reduction side. So obviously you've heard a lot over the last day or so on different harm reduction interventions, and people will be familiar with what those are. And they have a range of different outcomes, but today I'm going to focus on BBV prevention and overdose prevention. So for BBV prevention, there are various different indicators, but obviously the key ones are the WHO ones in relation to scale-up of BBV prevention interventions and the impact they might have on things like Hep C elimination or HIV transmission. And obviously one of the key pillars of BBV prevention is opioid agonist treatment, and this data shows how the bio-behavioural surveys can be used to collect that data and monitor progress towards these targets. So what you can see on the left is the NESI data. and this is uptake or prescription of methadone in the last 6 months. So you can see for the whole sample, it's the blue chart, the blue bars, sorry. The orange bars are for people who actually present to the services for injecting equipment, who are attending for needle and syringe exchange. So they're perhaps a more at-risk population. And you can see roughly about 2/3 of them over time have been on OAT. And this marries what we see in the wider prescribing data. Now, we've tried to reflect some of the Australian data here, and that might look on the low side for what you would think is a high harm reduction coverage country. But when you read into the more depth of the report, there is some more written detail there about the rates being a bit higher among people who were last reporting injecting opioids. So it's nearer towards the 50% mark. But you can see, obviously, methadone is the dominant OAT here, with much less prescribing across both countries of drugs like buprenorphine. Another key pillar of BB prevention is needle and syringe provision, and I suppose promotion of my colleague Nora Palmateer's recent review, which is just published, confirming the effectiveness evidence for high NSP coverage and reducing risk of bloodborne viruses, but confirming that it's most effective when used in combination with other interventions such as OAT. And our syringe coverage in Scotland has largely been stable, although we noticed a slight drop just ahead of the pandemic, which is when our last data collection occurred. We're just about to go into the field at the end of this month for our next round of data collection. And that's something we started to observe within the wider needle and syringe transmission activity data from other sources. And then looking at testing, so this is testing for Hep C. And I've tried to bring in 3 different sources here to compare what we do. So the UAM data that Monica talked about earlier is on the left-hand side, the NESI data in the middle, and then the Australian data on the right. And this shows kind of trends in Hep C testing over time. And you can see the trends, particularly in the UK countries, are quite similar in terms of them being increasing over time, although it looks as if potentially a slight drop in what we've seen in Australia over corresponding years. And then this is data from Joe's team in Canada, which shows BB, obviously treatment as prevention is a big thing, and this compares treatment for hepatitis C, which is in the orange line there, and treatment for HIV, which is in the blue line, and this highlights that there have been significant increases over time, and particularly for Hep C, you can see that increase starting to go a bit higher post the DAA era in 2015. So again, these are all just good examples of how we can use this monitoring data to inform policies in key areas of BBV prevention. But beyond Hep C, HIV, BBV prevention, there are other areas where we can branch out and look. Monica's already said that they monitor prevalence of Hep B within their study. We don't actually monitor Hep B within NESI, or we haven't done for a long time, because there's not a lot of Hep B about in people who inject drugs in Scotland, largely because of interventions that have been implemented in the past, particularly universal vaccination. And people who inject drugs are more likely to be exposed to vaccination for Hep B because of settings in where it's delivered, particularly in prisons, and because of their likelihood of being imprisoned throughout their drug using career. And this is a paper which kind of highlighted the impact of prison-based vaccination on reducing prevalence in Hep B amongst people who inject drugs. And you can see up until about 2015-16, everything continued to look very good. We had very high rates of Hep B vaccination within our populations. But what we've noticed, not just in our data, but also in the UAM data in the last couple of years, is that Hep B vaccination rates have started to come down within this population, which is perhaps a bit of a red flag or an early warning about things that might be happening in that area, and something we really need to understand and investigate. And there are now pockets of small Hep B outbreaks occurring in different parts of the country, and we need to understand if they're linked to injecting drug use or not. And if you remember, this is before the COVID era, which perhaps enhanced vaccination hesitancy, so that's another thing we need to contend with moving forward. Just briefly to talk about overdose prevention. Now, the cascade of care is very familiar to people working in bloodborne virus fields. There's not a great consistent cascade of care in overdose prevention. There are different options or models for cascades of care out there, but we don't have a consistent one that everybody's working to, and I think that's something we need to address moving forward, and something we can learn from the BBV land on this. Now, there is this 90-90-90 one, which was very much targeted at lower middle income countries, particularly Kazakhstan, Ukraine, etc. And this was about making sure people had relevant training, making sure people who had been trained had access to naloxone, and making sure people who had the naloxone were carrying it on them at all times. And I just wanted to put this up there as this is a very simple framework that could be adopted by other countries outside of this. It shouldn't just be targeted at lower middle income countries. And one of the things the bio-behavioural data has elucidated for us is what we call the naloxone paradox. And the naloxone paradox is that there's lots and lots of naloxone being supplied, particularly in our country, but not a lot of people are carrying it about with them. It's either at home in a drawer, or it's been left somewhere else, or it's not always with them. And that's fine if people are generally using their drugs within a domestic environment and it's accessible. But lots of people don't use their drugs in domestic environments, they use them in public places. And if they don't have naloxone on them, it's kind of useless. It's not going to be there to reverse the overdose. And we've really seen that naloxone paradox in the NESI data over the years. You can see the blue lines are prescribing of naloxone and the orange lines are carriage, and there's a big difference there, although it's changed a bit in recent years. Now, the UAM data looks much more encouraging in terms of carriage, and you're going, what are they doing in England that they're not doing in Scotland? Why is everybody carrying it there? And we did a systematic review in this area, and what became clear across not just England and Scotland, but other countries internationally, is there are very different methods in terms of how people record carriage. So in Scotland, we ask people at point of interview, do you have your naloxone on you today? And that's how we measure it. It's a different measure in England, which is a bit less sensitive to that daily carriage. And that's very different in countries across the world. And we published this systematic review, and one of the things we recommended was a more consistent definition for this so we can monitor carriage rates, because carriage is absolutely vital to naloxone's effectiveness. And actually, one of the things that came out of that data that we published was a kind of public advertising campaign promoting carriage of naloxone. And you probably see some of these posters, well, you might see them if you're around Glasgow, if you're paying particular attention, but some of them are around Glasgow and various cities all across the UK. And this was aimed at just promoting carriage of naloxone as a kind of routine behaviour. And the origin of that was the bio-behavioural survey data. So just to summarise, bio-behavioural surveys are fun, and they can inform lots of different policies across the harm reduction spectrum, but they can inform them at all stages, from the design stage, the implementation stage, but crucially the monitoring and review stage. But they can also provide evidence of policy success, but also early warnings of problems. The Hep B one is a good example there. We've used our bio-behavioural survey really to inform the response to the HIV outbreak in Glasgow, very much as an early warning to areas of hotspot of undiagnosed HIV infection, for example. And they're very adaptable to new policies. So COVID's a good example there. I know UAM were able to adapt COVID questions into there. We've got COVID questions coming into our new round. We've got questions coming on drug checking services now that they're going to become a feature of Scotland. And I think Joe reflects maybe how we've adapted to things like drug consumption as well. And they've never been more important. I think yesterday confirmed that this type of data is really crucial moving forward. Thanks.
Thank you very much, Andy, for that presentation. And I'd now like to hand over to Dr. Joe Cox, who's a director of the STBBI Surveillance Division, Public Health Agency in Canada.
Okay, thank you. So let's see if this works. Yeah. So thank you. I want to thank Andy and others on the panel for thinking of this session, proposing it for INSU, and inviting Canada and me to be here today. My mission for this part it was to look at bio-behavioural survey data and how it's used in research. So quickly, what I'll try to cover are the track surveys in Canada, what they are exactly, look at the methods for people who inject drugs, the track surveys for this population, maps of sites in Canada, and an example of one of the descriptive analyses or surveillance results. And then turn quickly to direct and indirect use of bio-behavioural surveillance data, survey data in research, with a focus on HCV elimination and harm reduction policies. So the track surveys in Canada really, they represent our bio-behavioural surveillance system. These are periodic in nature and are focused on key populations. The four are listed here. The focus today is on people who inject drugs, but something to highlight is that by doing these surveys in other populations specifically, we do tap into people who use injection drugs who may not identify or present for the track survey for people injecting drugs. So it gives another part of the picture. These vary in how cyclical they are, and that's something that we're challenged with always, and making sure that financing is stable and that these happen on a regular basis. But the indigenous, people who inject drugs surveys have been the most regular, and there have been 4 cycles to date. The methods are very similar to what you've heard already. I'll just highlight some differences. I mean, we're a big country, so we work with 13 provinces and territories to establish agreements for either purchasing data or supporting the data collection. We aim for a sample size of about 2,000 overall. Our eligibility is based on injection in the past 6 months. So it's not ever injection, it's injection in the past 6 months for non-medical reasons. It's venue-based, as a lot of them are, convenience and snowball sampling, and a variety of harm reduction sites. And there is compensation provided to participants, which may vary across the sites and is dependent on those collaborators. The questionnaire is interviewer administered. There's a variety of domains that we cover, which you've seen already as well. Highlighting, substance use, injecting behaviors, certainly information for us to inform the continuum of care for HIV and hepatitis C, et cetera. And in phase 4, which happened in 2017, 2019, we added additional questions, recognizing the evolving nature of the information that we need. So questions on gender identity, other social determinants of health, the overdose-related experiences, et cetera. And then the biological sample, as many are doing, we're using a DBS, but in one site, one network called the SurveyUDE network, which is in Quebec, and one site there are 9 sites and 1 in Ottawa. They use oral fluid specimen. We've focused on HIV and hepatitis C testing over that time, and RNA for hep C was introduced in phase 3, that was in 2012. Here you can see a map of Canada and the phases as they occurred since 2003. Our last phase 4 had 14 sites participating, which is the largest since this began, about 2,400 participants. And I highlight SurveyUDE, the network, with about 9 sites because they actually use a unique identifier which allows for longitudinal analyses and estimates of incidence, and they've published on this as well. And here is an example of one of the publications from the Communicable Diseases, Canada Communicable Diseases Report, summarizing some of the observations from phase 4. Essentially, 65% cisgender male, 42% identifying as Indigenous, high levels of unstable housing at 63%, and the majority experiencing stigma and discrimination in the past 6 months, but high levels of HIV and hepatitis C testing, which is positive. Now, just to mention that the track surveys and these data are really important as a data source to monitor and report on progress for HCV elimination targets. They're listed here. They're old already. We have a pan-Canadian framework for action on sexually transmitted and bloodborne infections. These targets are being revisited now with the idea of having designing indicators for key populations, et cetera. And we will work very closely with the Blueprint to Inform Hepatitis C Elimination Efforts in Canada, which has been put together by a Canadian network on hepatitis C, and where this group is also working with provinces and territories to develop province and territorial level plans for hepatitis C. So there's work ongoing right now to revisit these targets, also to look at something Andy mentioned about targets for harm reduction. And we have a Canadian drugs and substances strategy that's been renewed, and where this coverage will be considered as well. Now, my mission, as I said, was to look at direct and indirect use of biobehavioral surveillance data in research. We've conceptualized it as direct use of the data, and this is really secondary analyses of data within biobehavioral surveys in an exploratory and explanatory manner using regression models and other statistical analyses. And then indirect use, taking these data to parameterize models, for example, in predictive and other analyses. And I'll say up front, my approach here was a non-systematic and opportunistic review of literature, really with the goal to identifying papers from some of our partners here today. So that's what you'll be seeing. So here you can see direct use of data in research to inform HCV elimination. I'm going to focus on the first two. This was already brought up today, so I think the morning session really set this up nicely as, having empirical evidence to support what we do. And so this was a paper by Iverson and colleagues from using the Australian bio-behavioural survey. And as shown earlier today, there was a really important shift from 2015 to 2017 using their annual samples. They could document a really important shift from the number of people, the proportion of people actually being treated for hepatitis C and cured. So those are the little blue people, light blue people. And then looking at population viremia as the dark blue and seeing a decrease in that. The slides earlier today highlight this has continued, and the trend continues to be positive. I think a good point of this paper is the fact that surveillance and monitoring are required to track progress, which is I think why we're having this session, is to advocate that these works continue. Here's work from Bardsley and colleagues using UAM and looking at data from 2011 to 2018. And on the top table, you can see, based on data on treatment history of people who cleared infection, there was, and using 2016 as a cutoff for pre-DAA and post-DAA, you can see a trend after 2017 of statistically significant greater odds of Hep C treatment. And also looking at the odds of chronic infection in the bottom table, again after 2016, a statistically significant lower odds of having chronic hepatitis C. Information supporting treatment as prevention and efforts to continue to do that. Now, turning to indirect use of data in research to inform elimination, I want to focus on a paper that's being presented this afternoon at 2 o'clock in room Dokart. By Pentelis Simartisidis. I'm not sure, apologies for pronunciation. So, and this was brought up introduced this morning as well. And here this is a difference in difference design and using NESI data to look at developing a counterfactual, to actually look at determining a causal effect. And an important part of this study is looking at treatment scale-up intensity in communities. But I won't say more, and I hope you'll go to the session to hear more about that. Turning to direct use of data in research to inform harm reduction. Andy alluded to this. This is research using the NESI data in 2017, 2018, and looking at willingness of participants in that survey to use drug consumption rooms. And it was possible to document very high levels of interest or willingness at 75%, and also some profiling of the people who inject that would use this service. So people who have injected heroin, cocaine, homelessness, public injecting, and having had an overdose. So and I understand that the drug consumption rooms are not yet in place, but there's a plan, and I hope that work like this actually contributes to some of those policy decisions. And then turning to indirect use of data in research to inform harm reduction, I want to highlight a paper from Canada, specifically in Montreal, and Charlotte Laniès-Delaunay. And Charlotte used a dynamic compartmental model of concurrent HCV and HIV transmission among people who inject in Montreal, Canada. And you also calibrated that to epidemiological data, not just bio-behavioural survey data, but also really rich cohort data from Montreal. Julie's had a cohort for many years, Julie Bruneau. Marina Klein has had one on co-infection for many years. So bringing together all that information to calibrate the model. And she looked at 4 scenarios: 1, scaling down testing treatment for hepatitis C, as well as reducing opioid agonist therapy and needle and syringe coverage to pre-2020 levels. The second scenario, only scaling down testing and treatment for hepatitis C. The third, suspending testing and treatment, which is very drastic, while scaling down harm reduction to pre-2020 levels. And then finally, the fourth, again, suspending testing and treatment for hepatitis C, but maintaining harm reduction for elimination. And I just want to highlight to the left, the top left, this is the scenario, as I said, where you've scaled down Hep C testing and treatment, but where you've got 2 scenarios of levels of harm reduction. And the darker red really refers to a pre-2020 harm reduction, so a gradual incline in the incidence of chronic hepatitis C, but slow. But if you maintain harm reduction for elimination, higher levels of coverage for OAT and NSP, you will mitigate that quite nicely. Similarly, for scenarios 3 and 4, here again, suspended diagnosis and treatment, you have a rapid increase in incidence of chronic hep C. But if you use harm reduction for elimination, you're able to mitigate it again. So this was an effort to see, well, when we get to elimination, what's going to happen afterwards? So very helpful to see the interplay always between diagnosis, care, and harm reduction. Finally, in summary, bio-behavioural surveys appear to contribute to a broad range of research, directly and indirectly, on hep C elimination and harm reduction. I think they have the potential for a variety of hypotheses, generating opportunities and research questions. And I haven't done that link, but I imagine we can all come up with stories where observations made in a bio-behavioural survey have led to questions and research studies, which I think is another effort or means of looking at the returns and impact of these works. And when we think about impact, I think we're talking about academic and other. And some of those are listed there, and that's inspired by some work from RAND Europe on Project RetroCite, looking at impact of research. But just the idea is to be very broad in thinking about that, and I think it's something that we should continue to try to do. So thank you, obviously thanking all of the collaborators for the tracks for people who inject drugs, the partners across the provinces and territories, obviously the participants, and then some of the people I work with at the Public Health Agency who helped with these slides. Thank you so much.
Thank you, Joe. Can I invite these three speakers to come up and join us on the dais? So what happens now is Sharon's just going to briefly introduce the discussion. For those who are joining online on the hybrid session, you can submit questions using the app. There are 2 mics. The plan is that if you want to come up to the mic, they could use this one here. I'm going to go and take that one and use it as a roving mic because the seating aisles are quite wide. Those in the middle who might want to ask questions might struggle to get out. So, Sharon.
Yeah, there should be another... here we go. Okay. Oh, here we go. I'll just bring all this up. So thank you very much to the speakers. I think hopefully you've been convinced of the role and the importance of bio-behavioural surveys in a whole host of reasons for that. These provide really critical data for us to monitor infection levels in our population who are injecting drugs. They give us timely data in terms of risk behaviours, and also they give us a really good understanding of the level of access and uptake of a whole range of services. And I just want to, we've really touched on 4 surveys, if we include the work from Australia there. Recognise there's probably a lot of surveys going on in other settings and countries, and really keen to hear from others in the audience. This wasn't just a focus on these settings. We're really keen to hear about others. And I put this slide up. This is something I presented last year at INSHU, which on the left-hand side there's quite a healthy number of data from various settings across Europe, 25 countries that are able to report on anti-HCV prevalence. But as you've heard earlier today, that's not really going to enable us to track progress on elimination. And you can see on the right-hand side here how it's really quite scant, the amount of data that we've got measuring viremia in populations across Europe. And I dare say even more scant if we go beyond Europe as well. So, really keen to kind of engage with others about, the challenges in terms of adopting bio-behavioural surveys among people who inject drugs. And these are just really some questions that we came up with to kickstart the discussion and look to see how we might promote these, as I see it, really central public health surveillance systems and other settings. But I wonder if first I know there's some people queued up here at the mic here. Do you want to come forward and ask some questions first?
Yes, thank you. Sophia Bartlett from the BC Centre for Disease Control in Vancouver. First, I'm going to start with a comment about the hepatitis B vaccine coverage, because we have actually observed a very similar phenomenon in British Columbia. First, looking at actual immunity levels. So we weren't looking at vaccine uptake, we're actually looking at the prevalence of people who had antibodies indicating that they were immune to hepatitis B, and this is in the prison population. And in 2021, it was about 20%. So much lower than what we would have expected. And then we've also actually noticed hepatitis B vaccine coverage among children actually starting to drop. And there may be an impact because of COVID-19 with immunisations that are delivered in primary care. In British Columbia, most of the hepatitis B birth vaccine doses are administered in a primary care setting, and so there was big interruptions to care there, and that may have impacted it, but it actually had started to slip below 85% coverage already before COVID. So I think we do really need to start thinking about what is driving these changes in vaccine uptake and coverage. And maybe there's also something to be said for waning immunity over time, where we've got birth doses being administered in certain populations. People who were born, before 1980, they may have better immunity because they were immunised as adults. So I think this is a really important observation, and we all need to think about it, figure out what's happening there. And then the second piece, I wonder if one of the ways that we can adopt bio-behavioural surveys is to integrate them with linkage to care strategies, because I know the TRACK survey, for example, in Canada, it's non-clinical testing. So, the results might be given back to people, but it's not considered to be a diagnosis. And I just wonder if we can have better bang for our buck with some of these types of bio-behavioural surveys, where we integrate clinical testing and linkage to care pathways with our efforts, because I think that's how we would get better buy-in from public health and other types of settings where we might want to administer these things, but we're also potentially going to be enhancing what we're offering to the population, right? So just wondering what your thoughts are on that, and is it something that anyone's already doing that we can learn from?
So two questions there. I guess Andy already highlighted a kind of a bit of a concern we have in Scotland in terms of dropping Hep B vaccine levels. I know England, the rest of the UK are doing more work in terms of testing for Hep B. I don't know whether you want to contribute in terms of that one, Monica.
So thank you, and really, really interesting to hear your observation in British Columbia, and it's a concern that we share both in the prison population, so those in contact with the justice system, and also people who inject drugs who might not have been in contact with the justice system. So in the UAM survey, we have self-reported vaccination uptake, and we've seen quite a marked decline more recently, as Andy highlighted, but particularly in our younger age groups. So Claire, who's in our team and here today, is planning on taking forward a piece of work to look at serological markers of immunity, because we currently don't test for that in the UAM. So we're sort of trying to work through how we might do that, and then also look at some of the drivers and barriers to vaccination uptake, both within clinical settings, so some of the more sort of systemic drivers and barriers, but also clients as well. And we'd be really interested to hear what you find in British Columbia too. It is certainly a concern. We haven't seen a similar decline in childhood vaccination yet, but really interesting to hear what you've observed.
Great, Joe.
Yeah, so I'll just add that, and thank you, Sophia. I think we are planning our next tracks, so this is the right time to have these discussions. So to think about hepatitis B testing. So thank you for that. So that's something we can look at doing. Can I go to the next part of her question?
Please do. I think there's a lot to kind of,
I think that's I like your suggestion, and it's something that I'm really challenged with. The idea is that, because, the anonymous nature is attractive. Yeah. I think there's something, but I agree as a clinician, it does feel like we're missing an opportunity. So I hear you, and this is something we're having some discussions about in tracks as well, but recognizing there are benefits and disadvantages. And I don't know whether my colleagues have thoughts.
Yeah, this trade-off comes up a lot, particularly when we're dealing with, so we've had an HIV outbreak in Glasgow ongoing for about 5 or 6 years now, and we probably found more cases in Nessie than sometimes our public health colleagues were diagnosing in the field, and there's this trade-off about can we arrange a model where people can be informed. But obviously we don't do point-of-care testing, so there's a delay between us finding out. So our solution at the moment is if people do want knowledge of their diagnostic test, then they can be signposted, usually within the same site, to get a diagnostic test, and that's the trade-off we have at the moment. But like Joe says, there is this balance between anonymous testing and anonymous surveys and then clinical pathways, but it is an ongoing balance. It's not affected our funding at the moment, but if it did come up in the future, then it may be something to consider. But the model, as it stands at the moment, seems to work, but there's always a slight tension, I would say, with that.
Just to comment from the UAM, it's a tension that comes up similarly quite consistently. There is, as Andy said, a delay, so when the DBS comes to us at our central laboratory, by the time the result would get back to the individual, if it wasn't anonymised, there would be a delay. The way we get around that is that we recommend that diagnostic testing is offered alongside the UAM, and so usually the diagnostic testing is either offered first, or we find that the UAM is actually a way into diagnostic testing, so it initiates that conversation with clients about sort of hepatitis C, and the feedback we get from peers and drug service staff is that actually it sometimes really helps with people taking up the offer of the diagnostic test. The other thing just to say is that currently it's our only data that tells us about individuals who are unaware of their diagnosis. It's a metric we need to work on a little bit more, but just to sort of flag that as well.
Yeah, I mean, I've had plenty of discussions over the years about whether we should be approaching this from an anonymous perspective or more from a named perspective. I think it's very much in the context that we're delivering these surveys in settings where there should be very easy access into doing testing and treatment, and that doesn't necessarily apply to other countries where I think that approach of using much more as a kind of a way of getting people into services might be much more attractive in other settings where there isn't as much easy access for these things. Do you want to come forward and take?
Yes,
please?
sure. Hi, Yumi Sheehan from the Kirby Institute in Australia. Great presentations, thank you so much for that. I just thought that I would quickly, before I ask my questions, also respond that we're doing a bio-behavioural survey in Australian prisons at the moment. We're just about halfway through, and we are doing an entirely point-of-care testing suite. So we're providing results to patients and linking them up to care. There are obviously some challenges with that, but we do find that it is a really great way to ensure that patients do get linked up to the care that they do need. So I'd be very happy to chat with you about that if that's something that you're interested in. My first question was actually very similar to Sophia's, was do you provide results to patients, and if so, do you link them to care? So that's already been answered. My second question is that given the high burden of bloodborne viruses in prison settings, is there any plan across any of your studies to actually start implementing a similar survey or biobehavioural survey in prison settings?
Mm-hmm. Would anyone like to?
Sharon might be better answering that one. I think we've done initiatives in the past, peripheral to Nessie, but linked to the same people involved that have done prison-based kind of bio-behavioural surveillance, and the prison service in Scotland do their own type of work. But there's not been anything directly in prison for a while. Sharon probably know more about that maybe from our end.
Yeah, we've done and indeed again anonymous surveys actually within prisons in the past, and these have been actually a very helpful tool to understand not just the infection levels in prison, but actually can tell us a lot about infection levels amongst the population injecting out of prisons as well. I mean, I think what's interesting, certainly in our context of Scotland and the UK, we do have opt-out testing where we should be actually getting a very high uptake of testing and could get should have good data in terms of bloodborne virus infection levels. I'm not sure whether we're quite there in terms of reaching those high levels in terms of opt-out testing to really understand that. So I think it's in the backdrop of that. If that was working well, you might not need a survey as much because you could rely on the opt-out testing data. So I think that is something certainly we need to be thinking about going forward. I don't know if others wish to comment on the prison side.
If I may just quickly add, I think it would also be really interesting to understand the survey components of the questionnaire component, not only the testing, the prevalence components.
Yes, that's what I was just going to say, that our opt-out testing uptake has dropped off more recently, but as Sharon said, we should be able to get the bio bit, but you're right, the behavioural bit would be really helpful. We don't currently have plans to. Within the UAM, we do ask about history of incarceration, but Viv, I don't know whether have we.
There have been historically surveys of BBVs in prison. I remember spending time going and recruiting people, but that was over several decades ago now. There has been discussions about modules, but there are complexities about working in prisons. There are lots of ethical issues about whether you can do so without people feel coerced because of the environment. There's also the issues about actually accessing various different types of prisons to get an understanding across the prison population. There are lots of complexities about doing it, which means it's much, much harder, as I'm sure you're aware, to do than in the community. But it is a valid thing to think about. But there might be other approaches that need to be thought about. Yeah.
I'll just add that in Canada, the prisons are managed by Correctional Services Canada, and they are planning a bio-behavioural survey shortly. And the great thing is they actually sought out our questionnaire so that, the behavioral aspect will have some consistency of measures, which I think is great. But that is going ahead. Again, that's for the federal incarcerated population, and then you get into provinces and territories and this represents people incarcerated for less than 2 years, and that's that's much more challenging for sure.
Yeah, that's great. Thank you. Would love to chat with you all a little bit more. I'll catch up with you later. Thank you.
Hi, Zoe Greenwald, University of Toronto. Great talks, everyone, and thank you for all the work you do. I have a question building off Joe's presentation on using surveillance systems for informing elimination targets or looking at harm reduction targets. If this is our goal and it's one that's a bit more kind of causal than a descriptive goal, which like surveys are traditionally using, do you think that looking at the goals could inform larger sample sizes? Because often when you're looking at disaggregating results by provinces, territories, other units, looking at the effects of interventions that might not have high uptake, different drugs that are entering the market, how can we kind of use our goals to increase the sample we would need to actually be able to measure those outcomes?
Great question, Zoe. Challenging one. I think you're right. When we start to disaggregate, we get into small samples, and it's very, very challenging. And I think it goes back to being able for us to continue to advocate to have good biobehavioral surveillance works in Canada, that they are truly cyclical, and that we advance our methods as we do this as well. So thank you for highlighting. I think it's a very important comment, and certainly something we need to do as we move forward. Thank you.
So in England, it's something that comes up quite regularly as a comment, particularly because our delivery of direct-acting antivirals is split across 22 regions called operational delivery networks, and they're all really interested in trying to understand whether they've achieved what they're defining as micro-elimination. So the UAM survey is powered to provide sort of a good estimate of Hep C chronic prevalence and how that changes and trends over time for England, and it's really well powered at the recruitment level that we have between 2,000 and 3,000, down to relatively low chronic prevalence, but that's when we're looking at changes in chronic prevalence over time. Where it becomes a bit trickier is how we then translate that into incidence, which needs to feed into mathematical models, and you really need to sort of be able to triangulate those data. But it is something that comes up quite regularly when we start thinking about sort of smaller parts of England.
Yeah, I think that's a really good question. I think Nessie punches a bit above its weight because their coverage is a bit higher, so we cover about 10 to 15% of our population of people who inject drugs. So that does allow us to be statistically powered to detect various changes, and the modelers use that. You've seen some examples of that this morning in some of the models. But I think one of the things we're partly promoting today is regular biobehavioural surveys, not ones every 10 years or every 20 years. Most of us are doing this work every 1 or every 2 years, and that builds its own statistical power, and sometimes you can pull surveys together over different periods. Or one of the things we're noticing now is we get frequent flyers or repeat attenders, so people that have participated in more than one round, and we're now able to start developing even a kind of synthetic cohort from the data of people who've been participating for a long time, which is now giving us potentially an additional research tool in terms of understanding some of these things. But yeah, it's a great question.
Thanks so much.
No, I think we're probably running out of time, but we could probably we'll take another question. We'll try and kind of wrap things up.
It might be a quick one. The answer might just be no, but it's not a problem. But my name's Sarah. I work at Drug and Alcohol Services in Australia. My question kind of relates to the first prompt, sort of challenges to adopting these surveys. I was just wondering if there's, because I suppose it seems from across the conference, people who inject drugs are clearly a highly, highly researched population. I suspect that people who attend a needle syringe program get asked to participate in surveys infinitely more often than someone who goes to the GP to get a script. I was just wondering if there's any sense from the community of whether they experience research fatigue and whether we have to kind of be mindful of that when we're thinking about how and when we extract data from that group.
I think that's a brilliant question, and I think what we do, we need to be very sensitive to the people we're working with, but also the settings we're working within. So we're working in, generally for us, we're working in very busy pharmacies that are dealing with a whole host of different issues. So part of the training is very much about the interviewers being very sensitive to their environment and adapting to the environment. So the questionnaire is designed to be as brief as possible, and the dry blood spot test, etc. as well, so that people can be in and out, but not in a way that people feel rushed. Because one of the things we find is the conversation between the interviewers and the participant, sometimes that's the only conversation that participant's having that day or that week or that month, because they are quite a marginalised population. So sometimes the trick is actually reining them in a bit, because people want to have a chat about their day, their week, how things are going, and that's part of the training. But yeah, they are a very over-researched population, but I think the populations we're dealing with are perhaps a wee bit more at the margins, and that's why we do get good coverage of like undiagnosed infections and things, because they're not attending maybe other services, or they're maybe reluctant to engage with some of these interventions. And we do, it's almost like a brand now. People are used to us coming out every couple of years, and there's a familiarity with it, which I think does help.
Just going to add, where it's been a challenge for us is some of the busiest services that might not have previously been used to delivering bio-behavioural surveys. So pharmacies, for example, has been difficult for us because they are very busy. They're not used to delivering the UAM.
And the only thing I'll add is the importance of the formative assessment that always happens in biobehavioral surveillance work. And you know, in working with our partners, it's part of assessing that population and whether or not we can move forward. So I think that would be part of what we would do, especially now in Canada, where we're thinking about our next cycle of tracks for people who inject drugs. It will be working with partners again and asking questions like that.
Thank you. Thank you very much. I think is that, are we kind of yes, next slide. Well, I'm gonna ask you, Viv, to cover this, but before I do, I'd just like to thank all of the presenters for giving you kind of a bit of insight into the kind of breadth of work that's going on with biobehavioural surveys. I think the attendance at this, I'm really encouraged by the attendance at this session, and I think there's probably more discussion to be had here. We've really just touched the surfaces. So please come and reach out to us for the rest of the conference. There may be scope for us to have a forum, an international forum, for us to kind of come together and discuss more on taking forward biobehavioural surveys, and would love to hear more from you. Viv, do you want to kind of mention this special issue?
Okay, so I'd like to reiterate the thank you to the panel and to you as an audience, and to our questioners for those excellent questions. There were lots of things we would like to talk about. We were forced into an hour-long session for something we'd hoped would have been much longer. So related to this session, There is a special issue of IGDP in the planning. Some of those involved are people who are actually on this panel, others are in the audience. We are issuing a call for papers. Information is on this slide. So if you are involved in running a bio-behavioural surveillance system, particularly, or surveys which are repeated, or use data from those surveys, or have perspectives on that, as someone mentioned, research fatigue, but also about what is the role of people who use and inject drugs in developing and sustaining those surveys. It's important that we don't see these. These are often run, from within top-down structures, but actually they should be for and with the community, not something that's imposed upon them. So I think there are whole lots of issues to think about here, and complexities and tensions. So we're looking for a broad range of submissions. If you're not sure whether it's relevant, then do email Dan Allure at UCL, whose email's there, and who is in the audience at the moment. If you are unclear, Dan's there. Or if you're interested, do grab Dan, Monica, myself, Peter Vickerman, amongst others who are involved with this collection. We will also be approaching some people that we know to commission specific pieces as well. But we're interested in anything related to bio-behavioural service, particularly those that are repeated over time. Thank you. And thank you for coming along to this wonderfully well-attended session. And can we have a final round of applause for our speakers and our press